alumni. We are in the 17th of the series of the academic activity. Today we have Dr. Jagadish Hegde, who is a senior consultant cardiac anesthesiologist. He has fellowships in cardiac anesthesia, critical care, as well as pain medicine. And he is a teaching faculty at Sparsh Hospital, Bangalore, for DNB students. He has vast experience in cardiac anesthesia. He previously worked at Narayana Hospital, Bangalore, as cardiac as well as the transplant anesthetist. He is a regular speaker at national and state level conference. Over to Dr. Jagadish Hegde. He will be speaking on optimization of cardiac patients coming for non-cardiac surgeries. Dr. Jagadish Hegde, please share your screen and start presentation. Over to you, Jagadish Hegde.
Okay, Kiran.
Yeah, we're able to. Yeah.
Okay. Thanks, Kiran, for the introduction. Good evening, dear teachers and colleagues and friends. Today I'm going to speak on the important topic for anesthesiologists, that is optimization of cardiac patients coming for non-cardiac surgeries, with a little bit update. So you'll be, what I've heard or read about this topic many times in many stages, like conferences, CMEs, books, journals. So still this cardiac patient coming for non-cardiac surgeries is an enigma. So I just want to recap whatever we gone through so far in this topic, and since there is not much time constraint, I just want to remember some of the happier moments in Ballari. This was a photograph taken when we were in internship in front of the Department of Anesthesiology, and after 1 year, me and Kiran landed up there only. This talk I would like to dedicate to our beloved late Murthy sir, who was teaching us open drop ether method with Lakshmi Madam, with our first HOD and teacher, Dr. Mariswamy, and our parents-like teachers like the Gurudat, mentors like Balbaskar sir and Asu sir, and colleagues and friends. I think it's some Mysore or Bangalore, I don't remember. I think it's in Mysore. Okay, with that background, I would just like to start my topic. This topic doesn't need any introduction. It's so important because of the importance of cardiac patients coming for non-cardiac surgery, how we should prepare these patients for a particular procedure. As all of know, there is an increase in life expectancy globally. So a lot of patients with now 60 years, 70 years, 80 years are coming for the hospital. They might have had prior CABGs or other interventions like stenting or other things, and now coming for surgeries, many surgeries. They will be on many medications, and they definitely will be having more comorbidities like diabetes, hypertension, thyroid issues, endocrine issues, other things. So our main goal is to concentrate on this major adverse cardiac events during the surgery, like angina pectoris, MI, arrhythmias, and heart failures. So you have to prevent these events. So we have to evaluate these patients properly, and whether we have to advise them for the testing or medications, etc. And so for that, three things. Okay. See, for example, we may come across these patients like a 65-year-old patient with diabetic hypertension with history of MI or medical management coming for TERP, or 70 years old patient with history of stenting to main coronary vessels 7 months back coming for reducible obstructive inguinal hernia, like semi-urgent surgery. 72 years old with history of CABG 6 years back coming for TKR. 45 years old lady with history of DVR 2 years back coming for lab cholecystectomy. These patients with so many comorbidities, and they will be on so many medications. So these patients, managing these patients for non-cardiac surgery is a challenge. So always they say prevention is better than cure. So we have to take a lot of precautions while taking up these type of cases. So three things are important. These are the questions. So these patients, whether they can have reasonably have good non-cardiac surgery, or whether they need further evaluation, or any medications to be started, or whatever they are on to be continued, or if coronary revascularization is done, whether it protects the heart for non-cardiac surgery. These are the questions we should be able to answer at the end of this topic. So this is the importance of preoperative optimization. So there are three factors we should be concentrating on. There are risk factors related to patients. There are risk factors depending upon the surgical profile, surgical procedures, and most important thing is patient current activity that is evaluated by MET scoring system. So linking these three, and we have to risk profile the patient throughout the perioperative period. So obviously it's a team effort, though we know many things, but we have to involve surgeon, cardiologist, any other specialists like nephrologist or endocrinologist. Cardiologist role is important here while evaluating and doing further testing. So people started doing different scoring system to profile the risk involved. So Goldman started his cardiac index system earlier, then the Duke activity system came. Now we are following revised cardiac index, which consists of 6 factors like ischemic heart disease. In that, we have to know history of MI, history of positive treadmill, use of nitroglycerin, current complaints of chest pain to ischemia, ECG showing abnormal Q waves that indicates past MI. Congestive heart failure, history of heart failure, pulmonary edema, PND, peripheral edema. Cerebrovascular disease, history of stroke is important. High-risk surgeries are important, whether they are abdominal aortic aneurysm, other vascular surgeries, or thoracic or abdomen orthopedic surgeries. And diabetes control is very important. And creatinine more than 2 milligram is one of the risk factor. So this is patient-related risk, perivascular risk factors. We have to consider perioperatively. It is divided again into major, intermediate, and minor. Major carries more mortality, more than 5%, which includes unstable coronary syndromes, decompensated heart failure, significant arrhythmias, severe valvular disease. Intermediate, the risk, mortality risk is less than 5%, which includes mild angina pectoris, prior MI, compensated or prior heart failure, diabetes mellitus, especially on insulin, renal insufficiency. Minor here risk is very low, less than 1%, which includes advanced age, abnormal ECG, rhythm other than sinus, low functional capacity, history of stroke, uncontrolled systemic hypertension. And coming to type of surgery the particular patient is undergoing. Any emergency surgery which carries 2 to 5 folds increase in risk. And again, it is divided into three categories. High surgical risk categories include emergent major operations, particularly in the elderly, aortic and other major vascular surgeries, peripheral vascular surgeries, anticipated prolonged surgical procedures associated with large fluid shift or blood loss. Intermediate surgical risk category includes carotid endarterectomy, head and neck surgery, intraperitoneal and intrathoracic surgeries, orthopedic surgeries, prostate surgeries. And low surgical risk category includes endoscopic procedures, superficial procedures, cataract and breast surgeries. So the one more important thing is MET scoring system. It is related to oxygen uptake, and indirectly it indicates the patient's activity status. The one MET is expressed as resting or basal oxygen consumption of a 70 kg 40-year-old man in a resting state, which is 3.5 ml, is equivalent to 1 MET. So it is if a patient is showing more than 10 minutes, that is, if he is able to do strenuous exercises, the cardiac risk is very low. Whereas 4 to 7 is intermediate. Depending upon patient risk and surgical procedures, we have to decide whether to evaluate or do further testing. We have to decide. Less than 4 minutes, where our cardiac risk is very much increased. So, coming back to general approach, history is very important regarding symptoms of cardiac. Physical examination, you have to see related signs related to cardiac failures, and you have to go through other systems like pulmonary, diabetic mellitus status, renal status, other hematological disorders. And coming to investigations, these are some basic investigations. The ECG is very simple and very informative investigations, which is very important for us during perioperative period to diagnose either MI or arrhythmias. In blood, we should be able to know about patient's creatinine is very important, and glucose levels, and cardiac enzymes. So cardiac enzymes, as you know, troponin indicates ischemia, ongoing or recent ischemia. And more than that, nowadays people are monitoring natriuretic peptide and N-terminal basal natriuretic peptides, which indicates cardiac stress, and the level is very much increased in cardiac failure patients. And chest X-ray is indicated when the patient is aged, if he has any pulmonary issues, or if you expect in the post-operative period any problems, if you expect in the post-operative period. So So we have to link three factors like patient factors, surgical factors, and a MET, and decide for the further evaluations. These are the recommendations for ECG. It is from American Heart of Association. They have formed out recommendations for further testing in cardiac patients coming for non-cardiac surgery. Related to 12-lead ECG, it is a preoperative test. Resting 12-lead ECG is reasonable for patients with known coronary heart disease, significant arrhythmia, peripheral arterial disease, cerebrovascular disease, or other significant structural heart disease, except for those undergoing low risk. Preoperative resting 12-lead ECG may be considered for asymptomatic patients without known coronary artery disease, except for those undergoing low-risk surgery. Routine preoperative resting 12-lead ECG is not useful for asymptomatic patients undergoing low-risk surgical procedures. See, assessment of LV function is very important. Echocardiography is very important in these patients. So in echocardiography, more than ejection fraction, we have to look for regional wall motion abnormality. The heart is, the left ventricle is divided into 17 segments. So those regional wall motion abnormality is very important for us because each region, especially anterior, posterior, inferior, superior, are supplied by three different major coronary vessels. So that we should be knowing by seeing the ECG or echo, we should be knowing which part of the heart is affected by the coronary blockade. So it is reasonable for patients with dyspnea of unknown origin to undergo preoperative evaluation LV function. It is reasonable for patients with heart failure with worsening dyspnea or changing clinical status to undergo preoperative evaluation of LV function. Reassessment of LV function in clinically stable patients with previously documented LV dysfunction may be considered if there has been no assessment within 1 year. But routine preoperative evaluation of LV dysfunction is not recommended. So coming to stress test and myocardial ischemia and functional capacity, for patients with elevated risk and excellent functional capacity, it is reasonable to forego further exercise testing with cardiac imaging and proceed, and you can proceed to surgery. For patients with elevated risk and unknown functional capacity, it may be reasonable to perform exercise testing to assess functional capacity if it will change the management. For patients with elevated risk and moderate to good functional capacity, it may be reasonable to forego further exercise testing and with cardiac imaging, and you can proceed to surgery. Continuing this, for patients with elevated risk and poor METs, that is unknown or unknown functional capacity, it may be reasonable to perform exercise testing with cardiac imaging to assess for myocardial ischemia if it will change the management. Routine scaling with non-invasive stress testing is not useful for patients at low risk for non-cardiac surgeries. Cardiopulmonary exercise testing may be considered for patients undergoing elevated risk procedures in whom functional capacity is unknown. So coming to non-invasive pharmacological stress testing before non-cardiac surgeries, it is reasonable for patients who are at elevated risk for non-cardiac surgery and have poor functional capacity to undergo non-invasive pharmacological stress testing if it will change the management. It will be either dobutamine stress test or myocardial perfusion index using technetium or scans. Routine screening with non-invasive stress testing is not useful for undergoing low-risk cardiac surgery. This will be for patients who cannot do the stress, means exercise testing, TMT or exercise ECGs. So preoperative coronary angiography routinely is not recommended. So it is stepwise management of the patient, cardiac patients for coming for non-cardiac surgery. Patients with coronary artery disease scheduled for surgery. If it is emergency, you have to do clinical risk stratification with the time available and immediately proceed to surgery. If the emergency is not there, patient has ACS, then evaluate, treat according to generalized guideline directed medical therapy. If ACS is not there and estimated perioperative risk of MACE based on combined clinical and surgical risk, if the risk is low, that is less than 1%, there is no further testing is necessary, can proceed to surgery. If elevated risk, then if it is moderate to greater functional, if a patient has moderate to greater functional capacity, then there's no further testing is necessary, can proceed to surgery. If it is not or unknown or poor patient, if a patient has poor functional capacity, then if it is not there, then proceed to surgery according to guideline directed medical therapy. Or if a patient has these symptoms, pharmacological stress testing can be done. If it is normal, can proceed for the treatment. Otherwise, this coronary revascularization according to the clinical predictors. So, coming to coronary revascularization prior to non-cardiac surgery, revascularization before non-cardiac surgery is recommended in circumstances in which revascularization is indicated according to existing clinical predictors. It is not recommended that routine coronary revascularization may be performed before non-cardiac surgery exclusively to reduce perioperative cardiac events. So the very few indications for coronary revascularization for patients coming for non-cardiac surgeries, like established high-grade left main coronary arteries or left main equivalent, that is triple vessel disease or double vessel disease with proximal LAD or circumflex blocks. To some extent, patient with severe aortic stenosis. So in these very few patients, you can the patient can undergo coronary intervention prior to non-cardiac surgery. So coming to PCI, elective non-cardiac surgery should be delayed 14 days after balloon angioplasty and 30 days after bare metal stent implantation. Elective non-cardiac surgery should be optimally delayed 365 days after drug-eluting stent implantation. In patients in whom non-cardiac surgery is required, a consensus decision among treating clinicians as to the relative risk of surgery and discontinuation or continuation of antiplatelet therapy can be useful. To continue, elective non-cardiac surgery after DES implantation may be considered after 180 days if the risk of further delay is greater than expected risks of ischemia and stent thrombosis. Elective non-cardiac surgery should not be performed within 30 days after bare metallic stent or within 12 months after drug-eluting stent. In patients whom dual antiplatelet therapy will need to be discontinued perioperatively. Elective non-cardiac surgery should not be performed within 14 days of a balloon angioplasty in patients in whom aspirin will need to be discontinued perioperatively. So coming to other medical therapy like beta blocker therapy, there's a lot of controversies regarding beta blocker therapy, though it is found to be useful in reducing mortality and morbidity. There are certain recommendations. Beta blockers should be continued in patients undergoing surgery who have been on beta blockers chronically. It is reasonable for management of beta blockers after surgery to be guided by clinical circumstances independent of when the agent was started. In the patients with intermediate or high-risk myocardial infarction noted in preoperative risk stratification test, it may be reasonable to begin perioperative beta blockers. In patients with 3 or more risk factors like diabetes, heart failure, coronary disease, renal insufficiency, stroke, it may be reasonable to begin beta blockers before surgery. In patients with compelling long-term indications for beta blocker therapy, but no other risk factors, initiating beta blockers in the perioperative setting as an approach to reduce perioperative risk is of uncertain benefit. In patients in whom beta blocker therapy is initiated, and it may be reasonable to begin perioperative beta blockers long enough to advance to assess safety and tolerability, preferably more than 1 day before surgery. Beta blocker therapy should not be started on the day of surgery. So the summary is so beta blockers, whoever is on beta blocker, you can continue the beta blocker, or you have to start well in advance to get the benefit of beta blocker therapy in high-risk patients. But starting beta blocker just day before or on the day of surgery may not be useful, or rather it is harmful. Though it may protect a patient from MI, it may cause bradycardia, hypotension, and incidence of stroke is more in such patients. So we should be very careful using beta blocker. Statins to be continuous, no doubt. Alpha-2 agonists for prevention of cardiac events are not recommended in patients who are undergoing non-cardiac surgery for the hypotension reason. ARBs and ACBs have to be continued. If for some reason, if they are withheld before surgery, and it should be started as soon as possible in the post-operative period. I think this slide I have gone through. So coming to recommendation on the implantable cardiac devices who have preoperative reprogramming to inactivate tachytherapy should be on cardiac monitoring continuously during the entire period of inactivation. And external defibrillation equipment should be readily available. Systems should be in place to ensure that ICDs are reprogrammed to active therapy before discontinuation of cardiac monitoring and discharge from the facility. Volatile versus general anesthesia versus total TIVA. Use of either volatile anesthetic agent or TIVA is reasonable for patients undergoing non-cardiac surgery, and the choice is determined by factors other than prevention of myocardial ischemia and MI. Perioperative pain management is very important. Neuraxial anesthesia for postoperative pain relief can be effective in patients undergoing abdominal aortic surgery to decrease the incidence of perioperative MI. Perioperative epidural analgesia may be considered to decrease the incidence of preoperative cardiac events in patients with hip fracture. Prophylactic perioperative nitroglycerin is not recommended because it may cause hypotension. So intraoperative monitoring techniques. Again, T is a very important tool. It tells us the possibility of MI 5 to 10 minutes before it appears in the ECG. The emergency use of perioperative TE is reasonable in patients with hemodynamically instability undergoing non-cardiac surgery to determine cause of hemodynamic instability. when it requires, despite attempted corrective therapy, if expertise is readily available. The routine use of intraoperative TE during non-cardiac surgery to screen for cardiac abnormalities or to monitor for myocardial ischemia is not recommended in patients without risk factors or procedural risks for significant hemodynamic, pulmonary, or neurological compromise. Body temperature monitoring is recommended. Hemodynamic assist devices are recommended in the patients where unstable hemodynamic status is there, or other things like cardiac shock coming for non-cardiac emergence surgery. So we have ABP and impella, which are placed inside the body, which inflates and deflates and increase the blood supply to the heart and try to increase the myocardial performance. And other modalities are LVADs and ECMO, which are placed outside supporting myocardium. So, use of pulmonary artery catheters may be considered when the underlying medical conditions that significantly affect hemodynamics, like heart failure, severe valvular disease, combined shock status, cannot be corrected before surgery. Routine use of pulmonary artery catheterization is not recommended. See, it is always the use of pulmonary catheters is very much controversy nowadays. See, only the alternative is TE. Again, TE is cannot use. We cannot use it continuously. Whereas pulmonary artery catheters, though complications are there, it is used in perioperative setup for continuing monitoring. Again, blood glucose management is very important. Regarding valvular heart disease, indications for evaluation or treatment identical to those in non-operative setting. Symptomatic stenotic lesions associated with the risk of perioperative heart failure or shock, or regurgitant lesions are usually better tolerated perioperatively. Anticoagulants, as per ASA guidelines, I have gone through some of the anticoagulant usage. So whenever possible, aspirin low dose, that is 75 mg, can be continued throughout the perioperative period. These are the tables of ASA guidelines. This is use of warfarin to be stopped 5 days before. Whenever bridging therapy is needed, you have to do bridging therapy. This is regarding antiplatelet therapies. And this is the important table. I think everybody should have it with them whenever proceeding for non-cardiac surgery. If patients are on this anticoagulants, this include even newer anticoagulants like rivaroxaban, pandofanax, ticagrelor, prasugrelor. So it is an important table. It should be with us always, I think. So, so far I explained the investigations and medical therapy and risk factors, all those things. I forgot to mention this cardiac MRI. Nowadays, it is widely used. Cardiac MRI is widely used. It is a non-invasive testing method. It gives a lot of information about myocardium, its function, and other cardiac diseases. So regularly now in higher centers, they are doing cardiac imaging. And in therapy, a lot of other medications are coming, like analgin, which is a sodium blocker, yet to come. And people are trying a lot of different combination therapy, like beta blockers, statins with ACE inhibitors. But those drugs, I think, is still on the trial. They have to come. We have to see the outcome once they are into use. So the whole purpose is to avoid adverse cardiac events during perioperative period. We know by controlling hypertension and cardiac means heart rate. Hypertension or hypotension, tachycardia or hypo means bradycardia, all are detrimental to cardiac. They can precipitate the MI or arrhythmias. So we know what are the stages in the surgery where these can shoot up or drop down. Preoperative intensive care based on scant evidence, preoperative preparation in the intensive care unit may be benefit in certain high-risk patients, particularly those with decompensated heart failure. Anesthesia, again, technique is not is irrelevant whether it is general or regional anesthesia techniques. It depends on the person who is comfortable with the technique. And I went through about this in the previous slides. So coming to surveillance and management of perioperative MI, measurement of troponin levels is recommended in the setting of signs or symptoms suggestive of myocardial infarction or MI. Obtaining an ECG is recommended in setting of signs or symptoms suggestive of myocardial ischemia, MI, or arrhythmia. The usefulness of postoperative screening with troponin levels in patients at high risk for perioperative MI, but without signs or symptoms suggestive of myocardial infection or ischemia or infarction, is uncertain in the absence of established risk and benefits of defined management strategy. The usefulness of postoperative screening with ECGs in patients at high risk for perioperative MI, but without signs or symptoms suggestive of myocardial ischemia, MI, or arrhythmia is uncertain in the absence of established risk and benefits of defined management strategy. Routine postoperative screening with troponin levels in unselected patients without signs or symptoms suggestive of myocardial ischemia or MI is not useful for guiding perioperative management. To summarize, cardiac disease is becoming more and more prevalent every year. So the fraction of your patients who will have significant cardiac disease will also be on the rise. Careful preoperative evaluation and testing will reduce the morbidity and mortality associated with any patient who has pre-existing cardiac disease. Unfortunately, due to time pressures and surgeon pressures, you may be tempted to just go for it and hope for the best, but don't. It will ultimately be your ass hang out or dry, and surgeon will be saying that anesthesia never really told me how sick the patient was. So stick to your guns and make sure that the patient and safety comes first. So going through some of the memories in the OT. Is our trip to our native place. Malana sir, Srivasu sir, and the still kids, Govindra sir. With Srivasu sir, Murthy sir, Shivan sir, and Jivra sir. This man you can identify. Thank you.
It was a very comprehensive and exhaustive presentation. I think the forum is open for questions. First, I want to have some comments from Gurdev sir and Bhaskar sir, then we'll proceed to question and answers. So, Gurdev sir.
Yeah, thank you, Kiran, and excellent, lecture by Dr. Hegde as usual.
Thanks.
And it was in detail, actually, everything what a postgraduate requires. So it is from pre-anesthetic evaluation to anesthetic management in a patient with cardiac disease posted for non-cardiac surgery. very effective talk, Dr. Hegde. So one common question or one, still we have a lot of dilemma in these two drugs, especially one is aspirin when the patient is on 150 milligrams aspirin. Another is when the patient is on AC inhibitors, because no guidelines say that AC inhibitor should be stopped or should be continued on the day of surgery. And again, aspirin, as long as it is low dose, we keep on telling low dose, low dose. Low dose is 75 milligrams. But what if a patient is on 150 milligrams? Can you just highlight on these two things, AC inhibitors, ARBs, and aspirin 150?
So this thing is always controversial only. So in our practice, we continue AC inhibitors with the patient has cardiac issues.
Mm-hmm.
And if possible, we'll try to reduce this aspirin from 150 to 75 mg. If
on the day of surgery. Is it on the day of surgery?
No, just before, 2-3 days before only.
Okay.
See, patient comes 4-5 days when he comes to the surgeon and comes to the PSC clinic. If he is on 150 mg, then we'll ask them to reduce the aspirin, 75 mg.
Okay. How about AC inhibitors and ARBs?
AC inhibitors, if cardiac symptoms are there, we try to continue it.
No, because majority of the times these patients will be on AC inhibitors or ARBs for hypertension.
Yes,
and of course, if it is for cardiac failure, definitely we'll continue it.
yes,
but if it is for controlling the blood pressure, so majority of the books say that, even Miller says that on the day of surgery, better to stop. So
yes.
One doubt is, suppose if I stop, if the patient is only on AC inhibitors, if I stop on the day of surgery, there is a probability of a sudden increase in the blood pressure.
Yes, sir.
When he comes to the OT and on table. So again, we'll have a lot of problems. So
Yes,
this is not being given in any guidelines. What to do? Should we stop? Should we continue? If we stop, whether should we change over to any other anti-hypertensives?
My limited experience, in our limited experience, we are continuing it, because if you stop AC inhibitors, you have to start other nitro preparations that is more harmful than AC inhibitors.
Yeah, that is the problem, because why it is said that AC inhibitors or ARBs to be stopped on the day of surgery is refractory hypotension the patient may develop if we continue.
Yes,
so that is still a lot of doubts whether to continue or not to continue. Now we have started continuing. We are not finding much of refractory hypotension on the day of surgery. So I used to teach all the students to stop the drug on the day of surgery. Now, of course, of late we have started using that, making the patient to take the drug and then come to the OT, and we are not finding much problems as such. So I think that's what you also said, that because all other antihypertensives will continue on the day of surgery.
Yes.
Probably only the diuretics like loop diuretics, furosemide, you may have to stop on the day of surgery, but otherwise all the drugs we are going to continue.
Yes.
So this is one thing, and the other aspect is patients with atrial fibrillation, and sometimes they would have been well controlled, but when they are come to the OT, their heart rate would be around 90-100. So because any patient with uncontrolled heart rate of atrial fibrillation is an active cardiac condition. And what to do, Jagadish, on that day, morning, when he comes with a higher heart rate?
Okay. So we actually use either beta blockers or calcium blockers like digoxin, not diltiazem, to control the heart rate.
Yeah, the thing is, should we accept him, or should we, because he has not been properly controlled, we can postpone the surgery and then control it properly.
If that possibility is there, we'll try to control him for another 2 days.
Okay, that's because
after induction or during induction, then we have to use these drugs. If there is any hemodynamic instability, even we have to consider defibrillating.
No, all those problems you can anticipate in a patient with the uncontrolled rate of atrial fibrillation when we take him up for emergency surgery. But when we are taking him up for elective surgery, I think it is better to postpone, control the fibrillation, and if the patient, majority of them can be on even anticoagulant therapy also. That already you have explained what to do with oral anticoagulants and bridging therapy and all those things. So one more, we had a problem, like a patient, we had placed an epidural catheter for abdominal surgery. The same evening, the patient developed, MI, and they had to take him up for revascularization procedure. So stenting was done, and he was put on dual antiplatelet therapy. Now, what to do with the catheter? Catheter was not removed. So because we will not be, ideally speaking, if the patient is on anticoagulants or dual antiplatelet therapy, you are not supposed to remove the catheter.
Yes, sir. Yes, it is totally, sir. It has happened so many times for us.
Yeah.
We don't know what to do. We removed as early as possible. That's all.
Now, what we did was we waited for 3 days.
Nothing is there on this, especially about Preoperative.
Correct. Actually, what we did was we waited for 3 days, gave him epidural for his abdominal, pain, because abdominal surgery he had undergone. So then after 3 days, we removed, and then we observed him for any neurological problems, because epidural hematoma and other things. Fortunately, he did not have any problems.
Yes, sir.
So
and
otherwise,
that is the one thing, and practically we faced many times. See, we write to not to give clopidogrel till epidural catheter is there. We write and go in the night. Sister will continue the clopidogrel.
Yes.
It happened. One or those without our knowledge would have gone.
Correct. No, but again, that problem is still there. Clopidogrel, and many people say 3 days you stop, 5 days you stop, 7 days you stop.
Yes, sir.
Actually, what is it? 5 days, 7 days, 3 days? Ideally, is I think 7 days, but 5 days is the minimum period.
Yes, sir.
Is it 3 days?
No, sir. Definitely not.
Really
7 days. We are all accepting 5 days for Preoperative. Definitely not 3 days.
Because
I heard. I contact with my friends in US and UK. It's unofficially some of the semi-urgent surgeries they are doing on the second day or third day. It is not yet published yet. Nobody has opened their mouth. They are practicing it, but still 5 days is the norm, I think.
Okay. Because why 5 days? It is said that because a lot of postgraduates are there. The clopidogrel half-life is only 6 hours.
Yes.
After 6 hours, half-life, 50% of the drug will not be there in the circulation. But all the platelets which are in circulation would have been affected by clopidogrel at that particular moment.
Yes.
And per day, 10% of platelets are actually released into the circulation from the bone marrow. And 5 days, if we wait, at least will be about 50% of the platelets will be there, which have not been affected by clopidogrel. So that definitely will prevent any sort of bleeding problems. So that is the idea of stopping clopidogrel for 5 days and taking up later. So that, but as you said that many people are taking even the next day without stopping the clopidogrel, and fortunately nothing has happened. But if something happens, very difficult to explain in the court of law if they are taken up in the court for the court. Yes. Okay. Thank you, Hegde. Thank you so much for a nice discussion also. Thank you.
Thank you.
Yeah.
Bhaskar, sir.
Much of the discussion has been taken up. But one technical aspect is there was some confusion about succinylcholine and statins. I think it has not gone forward in terms of investment. About 10 years ago, I remember that probably 8 to 10 years ago. So statins, when we talk about patients being on many drugs, including statins, apart from anticoagulants and antihypertensives.
Okay.
So some discussion went for some time, and there were some investigations that those patients who were on statins and who were administered succinylcholine. So there was a greater risk of the myoglobinemia and other things which could possibly be more dangerous for the patient. They did find some increases when they compared the two groups, one patients who were already on statins and other group where it was stopped and succinylcholine was administered in both the groups. And they found that there was increase in the breakdown products, in the sense muscle damage. So muscle damage evidence in terms of myoglobin and other things were more. But in terms of any clinical consequences, they did not find any. So that was there for some time. And is there any change in that, Dr. Hegde?
No, sir,
Many of us may not be using, but when we talk about non-cardiac surgeries, there could still be people who are using succinylcholine.
Sir, actually, I don't know about succinylcholine and statins, but when they started statins, it was known to cause severe muscle pain in a lot of patients. So they used to start with 20 or 40, then they used to reduce to 10 mg. Maybe it is 10 years back, where that time I think we are using choline also. Nowadays, statin, they are continuing it without any problem. And in practice, choline is we are not using much. So that might be the one reason. Otherwise, I don't know regarding this.
That was the main point of discussion.
Yes, sir.
Basically, with respect to other thing about statins was some arrhythmia, predisposition, something was one topic. Then the second one was related to succinylcholine.
Yes,
other interactions were not basically there. And one more small but simple point for the PGs I would want you to convey is about the ECG diagnosis of perioperative MI.
Yes, sir.
So can you just briefly tell them?
No, I don't think so. Recently, I could not find any studies regarding the statins and choline.
Okay. No,
I don't know about that actually.
Okay. No, that's all. I think it died down, I suppose.
Yes, sir.
Basically, it was not significant. The other question I am raising is just for you to briefly tell about the ECG monitoring in non-cardiac patients. Cardiac patients coming for non-cardiac surgeries. It's quite a basic question. I still find that PGs straight away talk about troponins and other things.
Yeah.
Just intraoperative ECG findings and how you monitor the patient through the ECG for perioperative cardiac events, mainly ischemia.
Yes. ECG, as I told you, is an inexpensive and very important tool in our perioperative monitoring setup. See, in the preoperative period, we can diagnose prior MI by seeing at QA. Or if a patient has recent MI, it may show ST elevations. Or if you pre-op or perioperatively, ECG, we can diagnose by seeing ECG with ST segment elevation or depression. If it is ischemia, it may show ST segment depression. If it is ongoing ischemia going for the MI, then it may show ST segment elevation. And associated symptoms like hypotension, other things. When the patient under general anesthesia.
Yeah.
If regional anesthesia, the patient may complain of other symptoms also.
There could be some clinical features.
Yes, sir.
So what I found and would want the PGs is, for example, they must try to use the pilot ECG.
Yeah.
Very simple thing they tend to forget.
Yes.
Of course, it should be routine as much as possible, the pilot ECG. But when you talk about a cardiac patient for non-cardiac, they must specifically do it, number one.
Yes.
And these are technical points that they fail to do. And second thing is the monitor setup, the ECG monitor setup in terms of checking that the options for ischemia, ST segment, measurements, checking the J point, checking that the inbuilt alarms are activated. for ST segment and arrhythmia analysis and all. So these many times they would disarm the alarms.
Yes, sir.
Okay, so if it is arrhythmias, I will not bother much. But if it is in ST segment related alarms, so it will be permanently alarmed. I mean, alarm will be silenced, number one. And number two, they would not check on the measurements of ST segment.
Yes, sir.
It is shown on the monitor, because all of us know it is a monitor and the display would depend upon the size of the monitor, and we may not be able to exactly visually say, yes, just like looking at a static printed ECG.
Yes, sir.
So we must depend upon the computer, which of course very helpfully gives us the ST segment elevation, depression, then the PR interval, the QT interval, everything we get perfectly. What I find is this option is underutilized by the trainees.
Yes, sir.
So that's what I wanted to
My advice to all the PGs who are finishing or whoever joined, they must undergo cardiac training at least for 3 to 6 months in good cardiac setup.
Thank you, sir.
In good cardiac setup, where the importance of ECG and intra of MI or arrhythmia diagnosis, all these things can be understood. Straight away, if they start practicing non-cardiac surgeries, they will not even see ECG also.
Yeah, these times of cross consultation, no, we should not have a tendency to refer to the cardiologist.
Yes.
So we should not forget about the basic knowledge of cardiology related anesthesia. Definitely ECG,
yes,
echocardiogram, reading the echocardiogram report, and of course we also talk about the stenting aspects and the patients are being on pacers and other implanted devices. So basic knowledge is very important. There are some questions
in the chat box.
Chat box.
Yeah. One question from Dr. Harish. What is the ideal time to start beta blocker prior to surgery? Ideal time to start beta blocker.
This is the recommendation. So patient who are on beta blockers, it has to be continued. Okay. And see, on the day or 1 day prior starting beta blocker is useless. Maybe you can take a week or 10 days. If you have time to start beta blocker for 7 to 10 days, it will be ideal. You will have some benefits. Okay. If you start day before surgery, on the day of surgery, it is useless. It causes more harm. I think that's ideally 1 to 2 weeks before. Okay. If at all the patient requires beta blocker therapy. Okay. So, one more question.
Dr. Jagadish, actually, in all the guidelines, it is said that at least 24 hours before.
They say, sir, the same thing they say early starting, the day or previous day starting of beta blocker is detrimental to the patient.
No, on the day of surgery, yes, of course. That was
I went to some of the
voice trial. Voice 1 trial had decided, found out that perioperative MACE, though it was reduced, but stroke incidence was very high. So that's why they recommended that on the day of surgery, do not start that to high dose of non-selective beta blockers. So now bisoprolol is a highly selective beta blocker, because when they use non-selective beta blockers, stroke incidence was very high. Yes. 30 days stroke incidence mortality, though MACE, major adverse cardiac events, decreased. Yeah. That's why they said that do not start on the day of surgery. But now they recommend that, even 2014 guidelines recommended that 24, at least 24 hours before. But as you said, ideally it is at least 1 week, because we can titrate the dose. Many times, we don't know how the patient reacts to beta blocker. Suppose if I just start the patient on just 24 hours before, he may react adversely. Yes, sir. That's why if you have sufficient time, about 7 days, then you can titrate the dose, whether to increase the dose or decrease the dose. I think that's how ideal would be, at least 1 week before one should start beta blockers.
Yes, sir. They mentioned this 1 day before starting for the patients of high risk category and high risk surgery.
So one more question is how early or late, or whether the clopidogrel should be continued or stopped before surgery?
Which one?
Clopidogrel
Clopidogrel, again, everybody is concerned. Just once again, you repeat.
should be continued or stopped before non-cardiac surgery in a cardiac patient.
See, it depends on the I already discussed. The 5 days before the surgery, it has to be stopped. Though ideal is 7 days.
Okay.
And if epidural catheter is not there, you can start as soon as possible. If catheter is there after the removal, you have to start. Till that time, patient has to be on other heparin alternatives.
Yeah. And how? What is the ideal time to restart after surgery? Is the ideal time to restart clopidogrel or low molecular weight after surgery?
If you are given spinal, maybe after 6 to 8 hours.
Okay.
Or usually the aspirin and clopidogrel dose will be given in the afternoon. Okay. So if surgery is over by 12 o'clock or 1 o'clock, next day you can start. If it is over very early in the morning, you can start in the evening. If epidural catheter is there, after the removal only you have to start. 4 to 6 hours after removal of the catheter.
So one more question is management of perioperative myocardial infarction. How do you manage perioperative myocardial infarction?
In a non-cardiac setup.
Yeah. Patient coming for a non-cardiac surgery.
Okay. So options are very less. You have to optimize. We have to see the etiology, whether it is the lighter plane of anesthesia or whatever. You have to correct that. You have to correct the fluid status. Then you have to try to maintain the hemodynamic stability by optimizing anesthesia, fluid management, and if needed, inotropes.
Is there any scope for intervention, particularly you are in the operation theater and you have a Kerala by the side? Do you take the patient for primary PCI, coronary intervention?
No, actually.
Okay.
I have not seen.
Okay. I think the risk is with the bleeding because of the use of anticoagulants and heparin.
Usually, what we used to do is stop the surgery between and take the patient to the ICU, stabilize, and do the further management.
But still, it is a controversial topic.
A lot of headaches. And even a lot of setups are not, at least even Narayana uses, Sparsh uses, even though they are cardiac hospitals, still we struggle to do all these things. See, many times if problem happens in the OT, cath lab would have been very busy. So a lot of practical issues are there. So better to stop with the surgery, stabilize the patient, and take up the patient for the further management.
Okay. And Dr. Balasubramanian has asked one question. He wants to know diastolic dysfunction in preoperative echo and the occurrence of perioperative major adverse cardiac events. So is there any correlation between diastolic dysfunction preoperatively and the postoperative or perioperative MACE?
Yeah, it is there actually. If a patient has a preoperative diastolic dysfunction, we can expect mainly failures in the perioperative period. But patient coming for non-cardiac surgeries, for us, more important is regional wall motion abnormality rather than diastolic dysfunction.
Okay.
So that that is because our concentration is on IHD and valvulosis than this diastolic. Diastolic dysfunction will be there in aged patients, and they are prone for these failures.
So, I think there are no more questions.
No, associated failure with ischemic heart disease, definitely we should also be following it. No, associated, I mean, elderly patient with ischemic heart disease with associated diastolic failure, like those certain cases, there could be some reason for us to link diastolic dysfunction with, again, perioperative failure. It may not be the ischemic heart disease.
Yes, sir.
More about the failure aspect, less about the ischemic heart disease.
Yes.
And of course, systolic function will associate with normally the ischemic episodes.
Yes, sir.
So broadly speaking, I think that much can be anticipated.
Yes, sir.
Hello,
Yes.
good evening. Can we hear?
Yeah, we can hear you.
Okay, Kiran. Thanks, Jagadish, for the fantastic presentation. If you look at perioperative MI, if we go back to the pathophysiology, that itself tells us the management has to be different from a conventional medical ACS. That is a key for management of these patients. Here, the issue is not because of the stenotic blocked vessel. It is because of imbalance between the oxygen demand and the supply. So we need to address that issue more aggressively than looking at interventions. So that is probably what is going to save the day for us. So we need to concentrate on that. So as far as the beta blockers are concerned, they definitely have a role in this point. You need to control the heart rate. If the heart rate is going at 120, you do whatever, you are not going to get a good coronary perfusion, and that patient is going to suffer. So we need to get that heart rate down. There, we are giving an intravenous beta blockers, which is going to definitely control the heart rate, and we need to get it to a reasonable levels. That is crucial. In the meantime, improve the oxygen cascade, improve the supply of oxygen to the tissues, and maintain the hemodynamics so that the coronaries are perfused well. So these are the key issues when we are managing perioperative MIs.
Thanks for your input, sir. Thank you.
Is it Bharat? Who is speaking? Who are speaking?
Yes, this is Dr. Karan speaking.
Yeah,
yes,
because it is a galaxy.
Good evening.
You have to rename your
Okay.
ID.
Okay, I came in a little late, so I didn't have time. I just got into this. So that is why it is like that. Okay.
I want to add to this beta blocker intraoperatively. Before using, it will be the last option, tachycardia. We have to know what is the reason. Then only correcting all other reasons, then we can have to think of beta blocker.
No, it might be too late, Jagadish, to do things. We need to get that heart rate down, maintaining the hemodynamics. That is must. Address, yes, you need to address the cause for tachycardia. Yes, if it is primary cardiac event, if you suspect it is primarily a cardiac event, as somebody was talking about ST segments, there are issues related to that. So yes, a lot of people put off the alarm, as Bhaskar sir was saying, put off the alarms for ST segments. They don't look at numbers, which changes dramatically. Of course, there are issues again. There are patients who have got a strain and then ST is already down. So you'll have a -3, -0.3, 0.4 already. So we have to interpret in relation with the baseline what was there, whether there is a further depression or elevation or any change in pattern of ST segment. That is what we need to look at. So that is crucial. So if you don't do that, probably our interventions or our interpretations of that ST segment becomes irrelevant. So once we see all that happening, that means there is a cardiac event going on. If our suspicion is high, as we can do a point of care troponin, which can definitely give you little more information about it. We need to address that. If it's a suspected cardiac event, we need to address that. And percutaneous interventions, probably, as you said, even a setup like Splash or Narayana being so difficult to access, For us at the peripheral level, it's almost impossible. So we need to address it in a medical way. So that is how we need to go about perioperative MI management. And beta blockers starting electively 1 week before and things like that. Literatures are not many about that. One. Second thing is, even if you start on a patient who has got a major surgery and major risk, if you're starting them on oral, we probably will not be able to continue on that oral in the perioperative phase, because most of the patients will be especially I'm talking about non-cardiac patients, non-cardiac surgery patients. They are all on non-NPO and things like that. So we will not be able to give them. Even if we give them, how much is going to get absorbed also is becomes a little difficult. So we need to opt for probably an intravenous medication. If it is a extremity surgery or an orthopedic surgery and things like that, definitely we can use. We routinely use bisoprolol on these patients who are at a higher risk for cardiac events. We start them on bisoprolol. And last 8-10 years, we have done good number of major hip surgeries in an orthopedic center where we have routinely started this medication with the better outcome compared to when we were not doing it. I don't have the numbers to prove that or disprove it, but clinically what we have seen has given us better results.
But one more thing we could always be stressing nowadays is that we start doing the echo, because bedside echo, machines are available now, more widespread. Now we are talking about non-cardiac surgeries. So we can learn at least a FATE procedure. So basic things, focused assessment, the transthoracic echocardiography. So that can be tried, and basically we are trying to, of course, look for the left ventricular function broadly in terms of wall motion abnormalities and rough idea about the ejection fraction. So definitely I think this would help in better management of the patient when posted for non-cardiac surgeries.
Yes. In that I want to add, even though we cannot become cardiologists, but definitely two views, parasternal long axis view and apical short axis view, will give most of the information about the heart. And that can be done easily.
Yeah. Is it transthoracic or esophageal?
Transthoracic.
What we use it?
Transthoracic.
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 Okay.
Actually,
I have one. Yes, sir. Go ahead.
Yeah, it's very simple. No, I think we should be pushing for, within our operation theaters and in the ICUs of anesthesia department, wherever we maintain. So we should make it a routine habit even to check with a FATE protocol in the postoperative period and any doubts in the intraoperative period. So I think this would probably also become a matter of routine management or monitoring. So it's such a simple procedure. Dr. Jagadish, Hegde and others would know. So just putting the probe and trying to assess at least 2 to 3 views, the long axis view and any 4-chamber view and apical short axis view. Broadly, you'll get an idea how the heart is functioning. And if there are some warning features, even at that point of time, we can decide to again look back into the myocardial oxygen supply demand factors, as Dr. Karan was suggesting. And if necessary, could still stop the procedure or do something. So I think there is a good scope for using the ultrasound and the echo, cardiac echo in the perioperative period.
Yeah, if we can probably see wall motion abnormalities preoperatively, and how the left ventricle is contracting, these two things, and if we can see at IVC and how the IVC size is, these 3 things if we can make out, that makes a huge impact on the patient outcome intraoperatively. If there is a change in wall motion abnormality, or if there is a contractility change, or if the IVC is not well distending. So at least we know whether to go in for a pump stimulators or to go in for a volume, or we need to do something to reduce the oxygen demand and supply balance. At least this much we can make out. If we have understanding of very simple basic things, we need to look at only 3 components that if we can understand and routinely follow them, pre-op, intra-op and post-operative, 3 areas. If we can follow that, probably we can make an outcome better for a cardiac patient.
Yeah, recently in a neurosurgical patient, what we had was sudden hypotension the patient went in for. Actually, there was no cause for hypotension. So immediately we did a transthoracic echo, and then we found a thrombus in the right ventricle. So he had developed a pulmonary thromboembolism. So that's how, afterwards we managed him very well, and he could go out of the hospital without any problem. So that's how, we realized that intraoperative, transthoracic echo also can help us in sometimes to diagnose the problems. And another thing regarding Karanth was talking about beta blockers intraoperatively for tachycardia. But as Hegde was telling, that first we'll have to rule out what is the cause for tachycardia, because many times tachycardia can be because of bleeding, hypotension, hypovolemia. Intraoperative, that is the most common cause. So in such situation, if you just go for beta blockers without correcting the cause, I think beta blockers also will produce more problems, because the myocardial depression they produce, and more hypotension can occur and myocardial ischemia can occur in such situations. So best thing is to see what is the cause, try to see, treat the cause. Suppose if it is an unexplained tachycardia, you don't know what is the cause for tachycardia, patient is normotensive, and in such situations, definitely one can go for intraoperative beta blocker as the first thing to reduce the heart rate, because heart rate is involved for both supply and demand as far as the myocardial perfusion of oxygen is concerned.
So that's what the first reaction from all of us when there is a drop in blood pressure is to optimize the volume. That is what we look at. And then we look at whether it's a totally, most of our anesthetic cause of vasodilatation, so we tend to use vasopressors to get that pressure into reasonable numbers. And that is when, after that, when we look at heart rate, then we will probably be intervening with the heart rate, not as a first response. First response is always about the volume status. That is what we suspect, because that is the most common thing that can happen, especially in patients who are on ARBs and AC inhibitors. There are literatures favoring both ways, and you have to address that issue. And a few things, if I can add on, that is what probably can be practiced is, if there is a major fluid shift or a major blood loss expected in a given surgery, then probably it is worth holding on to the medications. Even a single dose holding on the day of surgery might be worth, because that will only add on to the hypotension. Whereas patients who are not expected to have such a major fluid shift, or the patient is going to go back on their normal thing as early as possible, then probably AC inhibitors, probably or ARBs probably can be continued, especially who are on chronic therapy. Even if you withdraw for one day, may not be that great a difference as far as the hypotension is concerned, that we may not see. But the combination of this with hydrochlorothiazide is what little trouble it creates. Again, when we use the thiazides along with, that is the usual combination. As you rightly said, use of ARBs or AC inhibitors for hypertension management probably can be taken a chance to withhold. But if it is for other purposes, as you said, for CCF and things like that, definitely it needs to be continued. That there is no doubt about that part.
So majority of the times, when hypotension occurs is as we induce these patients with the propofol,
yes,
patient is on AC inhibitors or ARBs. That is the time when we have,
exactly.
And that is what in majority of the books they say, that you give at least about 400 to 500 ml of preload for these patients before inducing them. So that is one of the precautions one can take before, if the patient is already on AC inhibitors and we have continued these drugs on the day of surgery. So slightly better to look for the volume status and then give propofol. And probably if you give propofol very slowly, like sleep dose, we can definitely prevent these hypotension.
They tend to misbehave even with the inhalation anesthetics. That keeps happening even intraoperatively. Even inhalation anesthetics, whatever we are titrating, when we give a reasonable level of anesthetic level of inhalation, they tend to misbehave. But as you said, fluids and a very effective vasopressor like phenylephrine. Other vasopressors don't work very well. Phenylephrine works quite well for these patients. The blood pressure comes up quite well with phenylephrine. So those two things probably will help us. As you said, preload to these patients with 500 to 750 ml of preload volume. And then if there is a hypotension, treat them with vasopressors. Because we know it is a relative imbalance between the volume and space available. when the patients are on ARBs or AC inhibitors. They don't optimize. I still remember you teaching us that it's never optimized. The volume, when you treat the patients with hypertension with AC inhibitors, the only problem is it treats the hypertension, but it will never normalize the volume. Whereas other antihypertensives allow when they are on a chronic therapy, volume gets normalized. So that is something which even today, after 23, 24 years after your teaching, I still adhere to that. And it works quite well for me.
No, but Karan, one thing is these patients with having refractory hypotension with AC inhibitors, the drug of choice is vasopressin, because they say that these AC inhibitors can produce vasoplegia. So because they produce vasoplegia, other routine classical vasopressors, what we use, ephedrine, phenylephrine, they may not be effective. So in such situation, the drug of choice is, they say that it's vasopressin, 0.04 milligram per microgram per kg body weight per minute infusion.
So that's about 0.01 to 0.04 units per minute. It's not related to per kg body weight. It's 0.01 to 0.04 units per minute infusion.
So that's
but many places won't have vasopressin ready.
Yeah.
But
that's why we call it a refractory, because refractory to all vasopressors, routinely use vasopressors.
But,
so then
I have been using phenylephrine with a reasonable good results.
Okay, right.
So that's the reason I said
always clinical experience is more important.
Phenylephrine works quite reasonably well for these patients. And they have a repeated bouts of hypertension. I start them on phenylephrine infusion, which holds on to the pressure, at least gives us the comfort numbers. I don't know whether it really improves the perfusion, but at least gives us the numbers.
Now, plus the heart rate will come down.
Yes.
That is an advantage.
So logically, we think, okay, we are doing good to the patient.
Yeah, correct.
One more question to Dr. Jagadish Hegde from Myocardial. Patients with medical comorbidities, is just 2D echo enough, or should we ask for stress echocardiography? What is your opinion, Dr. Jagadish?
That he has to undergo, he has to read back all the indications. Just medical therapy cannot decide. You have to see other factors also.
No, actually, he is asking for whether just a 2D echo is enough, or we need to do an stress echo too.
That depends on.
That depends, yeah. Depends upon the comorbidities.
Yes.
I think that would answer the query. Sir, if there are no questions, I think we had a very fruitful discussion and with a lot of input from Gurudhav sir, Bhaskar sir, and Karan sir. I think we can close the session, sir. Is that okay, sir?
We can close, and of course, Dr. Karan cannot be coming once in a year.
He should be a regular attendant, irregularly.
Dr. Karan, you must attend more frequently.
If I'm at home, yes, sir, definitely. But many times I'm not there at home. I'm on the street.
We have generally on the 4th Saturday, last Saturday, right, Kiran, basically.
Yeah, 4th Saturday.
I know.
Bhaskar,
you please speak.
I have not missed even a single one. I have not.
Yeah, that's what.
Yeah.
That's why you must attend, Karan.
Yeah, it will be helpful to a lot of postgraduates and other consultants.
Karan, yes,
sharing knowledge.
Gone back to medical college now.
I think me too.
I'm on paper with the